Dear colleagues, in a couple of minutes, I'm going to cover what is new in heart failure in 2020. This year, we have many important clinical trials which have been presented in the ACC, ECC, and AHA. So we will start by sodium glucose co-transporter inhibitors in patients with heart failure. Many mechanisms have been described for the beneficial effects of this new class of drugs in patients with heart failure. They block glucose reabsorption in the proximal convoluted tubules at SGL2. It leads to glycosuria, natriuresis. It reduces preload, afterload, and reduction in LV wall stress, reduction in interstitial edema, improve kidney function, and has a cardiorenal protective effect. This slide summarizes the different hemodynamic parameters which can be achieved with the use of sodium glucose co-transporter inhibitor, which at the end lead to cardiorenal protection. At the level of the circulation, it decreases plasma volume, arterial stiffness, systolic blood pressure, and increased hematocrit, decreased preload and afterload, and decreased wall stress. This will lead to increased cardiac efficiency and output. Sodium glucose co-transporter decrease glucose sodium reabsorption. It decreases intraglomerular pressure, decrease intrarenal RAS system activity, decrease hyperfiltration and inflammation and hypoxia. So at the kidney level, this will lead to renal protection effect. Cardiorenal protection will increase cardiac function and increase renal function. And this is responsible for the positive outcomes of this group in patients with cardiovascular disease, decreased cardiovascular outcomes, decreased heart failure hospitalization, stabilization of the estimated glomerular filtration rate, and decreased albuminuria. Look for WHF trial, one of the landmark trials for SGL2 inhibitor dapagliflozin and prevention of adverse outcome in heart failure. More than 4,000 patients with heart failure function class 2 to 4 with an ejection fraction less than 40% and the high levels of NT-proBNP for a mean duration of 18-month follow-up. Patients were randomized to receive the standard of care treatment plus dapagliflozin 10 milligram versus patients who received dapagliflozin and placebo. 45% of those patients have type 2 diabetes and 55% have no type 2 diabetes. If we look for the composite primary endpoint, which was cardiovascular death and worsening heart failure, it was lower significantly with a significant p-value and 26% in the primary outcome reduction, and the number needed to treat was 21 patients. If we look for the primary outcome, cardiovascular death, heart failure hospitalization, or urgent heart failure visit by diabetes status, we can see that the primary outcome, whether the patient is diabetic or not, the same significant reduction achieved with dapagliflozin 10 milligram. So DAPA reduced the primary endpoint regardless of diabetes status. Look for the components of primary outcome: worsening heart failure event and the cardiovascular death. Decreased the worsening heart failure event by 30% and the cardiovascular death by 18%. And if we look for all-cause mortality, which decreased significantly by 17% with dapagliflozin compared with placebo. Another drug, which is empagliflozin in a trial known as Emperor-Reduced trial. In Emperor-Reduced trial, the same patients were randomized to receive the empagliflozin 10 milligram versus placebo. Heart failure patients function class 2 to 4, ejection fraction less than 40%. In 3,700 patients, looking for the composite primary endpoint, time to first event of adjudicated cardiovascular death or adjudicated heart failure hospitalization. And the secondary endpoints, which is the first and recurrent adjudicated heart failure hospitalization events and slope of the change in estimated glomerular filtration rate from the baseline. The primary endpoint, which is the first adjudicated cardiovascular death or hospitalization for heart failure, decreased significantly with empagliflozin compared with placebo. And we can see that the relative risk reduction was 25%, absolute risk reduction 5.2%. If we look for the key secondary endpoints, adjudicated total hospitalization for heart failure, it decreased significantly with a relative risk reduction by 30%. The renal protective effect of empagliflozin was confirmed with the use of empagliflozin. Although there was initial drop in the estimated GFR with the use of empagliflozin, however, if we look for the slope of the estimated GFR slope, it improved significantly compared with placebo. The yearly decline of the estimated GFR was 0.5 milli per minute with EMPA compared with a yearly decline of 2.28 milli per minute with the placebo. We know that 40 to 50% of patients with heart failure have renal dysfunction. So with the use of empagliflozin, even in patients who have estimated GFR up to 20%, the renal protective effect with the empagliflozin was achieved. Another SGLT2 inhibitor, which is known as sotagliflozin, in patients with diabetes and recent worsening heart failure, in a trial known as SOLOIST-WHF Trial, in patients with diabetes and recent worsening heart failure, sotagliflozin therapy initiated before or shortly after discharge resulted in significantly lower total number of deaths from cardiovascular causes and hospitalizations and urgent visits for heart failure than placebo. So again, this slide showed that the primary endpoint decreased significantly in patients who received the sotagliflozin compared with placebo. Another important study, which is Victoria trial. Victoria trial, the rationale for using vericiguat in patients with heart failure, that worsening heart failure is common despite the use of guideline-directed medical therapy. And there is substantial risk of mortality or hospitalization after worsening heart failure event. So vericiguat, which is a novel soluble guanylate cyclase stimulator, is a potential new therapy. Victoria trial assessed the efficacy and safety of vericiguat in patients with HFrEF after recent worsening heart failure event. Again, the mechanism of action, why vericiguat is potentially a novel drug in patients with heart failure. We know that heart failure is associated with endothelial dysfunction due to increased oxidative stress and inflammation. This will lead to decreased nitric oxide synthase, which lead to decreased availability of nitric oxide, which is important for soluble guanylate cyclase activity, which is responsible for conversion of GTP to cyclic guanosine monophosphate. So deficiency of cyclic guanosine monophosphate lead to vascular and myocardial dysfunction. With the use of soluble guanylate cyclase agonist with increased soluble guanylate cyclase, which lead to more cyclic guanosine monophosphate, this will improve the heart and vasculature, decrease progressive myocardial stiffening, decrease myocardial thickening, decrease ventricular remodeling and fibrosis, and decrease arterial constriction and vascular stiffening. So vericiguat increased soluble guanylate cyclase activity to improve myocardial and vascular function. So Victoria trial randomized patients with HFrEF function class 2 to 4, EF less than 45%, receiving guideline-directed medical therapy. Patients have recent history of hospitalization or intravenous diuretic therapy. Patients who have a high levels of NT-proBNP. So randomized patients to receive vericiguat versus placebo, looking for the primary endpoint, which was a composite of cardiovascular death or first heart failure hospitalization. And in comparison to placebo, the use of vericiguat was associated with statistically significant reduction in the primary endpoint. The number needed to treat 24, absolute risk reduction 4.2%. Secondary outcome in terms of cardiovascular death and heart failure hospitalization decreased significantly, and the vericiguat significantly reduced the time to first heart failure hospitalization. Again, all-cause mortality or hospitalization decreased significantly with vericiguat, which is a secondary outcomes. So vericiguat reached the combined endpoint of all-cause death and heart failure hospitalization earlier after 3 months of treatment. The conclusion of Victoria trial, which address significant unmet need and different very high-risk heart failure population, once daily medication optimal for patients, safe pharmacologic profile, number needed to treat to prevent primary event 24 patients, and is considered a big step forward in treatment of very high-risk heart failure population. We know that we have 5 pathways which are detrimental in patients with heart failure. We have angiotensin II, norepinephrine, aldosterone, meprelizine, and sodium glucose cotransporter. So the availability of 4 drugs, the group of ACE inhibitor, ARBs, or ARNI, in addition to beta blockers to block the sympathetic activity, MRA, aldosterone antagonist, and the SGL2 inhibitors, dapagliflozin and empagliflozin, are considered the treatment of choice in patients with heart failure according to the guidelines. And we have also some drugs which are important, ivabradine in patients with heart rate more than 70 beats per minute, hydralazine, isorbide dinitrate combinations, and finally, vericiguat, which is a novel drug, soluble guanylate cyclase agonist in patients with worsening heart failure. The last trial, which had been published in 2020 for patients with heart failure, the Galactic Heart Failure Trial, which is the use of Omecamtiv Mecarbil in chronic heart failure with reduced ejection fraction. The rationale for using this drug, we know that decreased systolic function is a central factor in HFrEF patients. And unfortunately, the use of inotropic drugs was associated with increased mortality rate. So Omecamtiv Mecarbil is a myotrope and a selective cardiac myosin activator that improves cardiac function. The Galactic Heart Failure Trial evaluates the effect of Omecamtiv Mecarbil on outcomes in patients with chronic heart failure. So patients who have HFrEF with an ejection fraction less than 35%, function class 2 to 4, high levels of natriuretic peptides, history of heart failure, hospitalization, or emergency department admission for a primary reason of heart failure event within 1 year, receiving guideline-directed medical therapy, 25% of patients currently hospitalized for heart failure, randomized to receive Omecamtiv Mecarbil 25 milligram orally twice per day versus placebo, looking for the primary outcome, which was cardiovascular death and heart failure hospitalization, which decreased significantly with the use of Omecamtiv Mecarbil compared with placebo. And if we look for cardiovascular death, it decreased significantly. So this paper, which was published recently in the New England Journal of Medicine regarding cardiac myosin activation with Omecamtiv Mecarbil in systolic heart failure among those patients who have low ejection fraction and received a new inotrope Omecamtiv Mecarbil cardiac myosin activator, it lowered the incidence of composite of heart failure event or death from cardiovascular causes than those patients who received the placebo. Thank you for your attention.